Welcome to the new improved unRemarkable labs. I'm Bob Centaur, and I will be discussing a basic metabolic panel today. I have four wonderful residents with me from UAB who are going to keep me honest. Natasha is our fearless leader and host or hostess or both. And so why don't you introduce yourself and call on your other colleagues.
Sounds great. Hey guys, like Dr. Centaur said, I'm Natasha. I am a second-year resident at UAB. I'm interested in general medicine, and I'm originally from Memphis, Tennessee, and a huge Grizzlies fan. Miles, why don't you introduce yourself next?
Hi, I'm Miles Anderson, also a second-year resident and also from Tennessee, but grew up in Nashville and did enjoy the Grizzlies some during medical school.
Yasmin.
Hey guys, I'm Yasmin. I'm also a second-year resident at UAB. I'm originally from Texas and interested in GI.
And last but definitely not the least, Julie.
Hey guys, I'm Julie. I'm also a PGY2 medicine resident here at UAB. I'm interested in maybe ID, still not sure. And I'm from Winters, Texas.
Awesome. Well, let me go ahead and get our case pulled up. Okay, so today we're talking about a 50-year-old female who's presenting with 3 days of ataxia, confusion, and slurred speech. And we'll get started off with Dr. Centaur's favorite, RBMP.
Okay, so we'll keep that history in mind. And one of the reasons I like doing this is because when you get called from the clinic or the emergency department, you often get sort of a one-liner and the patient looks pretty sick. Before you go down to the emergency department, most interns and residents I know look at the labs before they've ever talked to the patient because the labs are available. And my hypothesis is that if we really study the labs, it may influence what questions we ask in a positive way. So let's look at this patient. We have a sodium of 141, that's real normal. We have a potassium of 3.8, maybe low, that's probably normal. A chloride of 105, but a bicarb of 16. So 16 is low. I add that back to 105, I get 121. So I have an anion gap of 20. So that's an abnormal anion gap. I have a BUN of 14, a creatinine of 0.8. Neither of those have me very excited, and a glucose of 99. So this looks like it's an anion gap acidosis. Do we have an albumin? The albumin is normal, so we're going to assume that the albumin is 4. So the anion gap was 105 plus 116 is 121, and subtract that from the sodium is 141. So that's how I got 20. What should the anion gap be? There's a complicated formula that nobody ever remembers. But one thing we've been doing at UAB for years, which I really like, is to correct for the albumin. Since the albumin's normal, what we do is we take the albumin and multiply it by 3. And so this patient probably should have an anion gap of around 12. That allows us to do a very interesting calculation, which is the delta gap. And the delta is the difference between the expected gap and the observed gap. So we actually see a gap of 20. We should have a gap of 12. We subtract those, that's 8. The idea is, and this is not a perfect idea, because the human body is not like a flask and tubes in chemistry lab. If we add that delta gap back to the bicarb, does it correct us back to a normal bicarb? In this case, it does perfectly because 16 plus 8 is 24. And so if the patient also had a metabolic alkalosis, when we add the anion gap back to the bicarb, we would have a high bicarb estimation. Or if the anion gap was fairly low and we added it back, we'd also have a normal gap acidosis. But this is a pure anion gap acidosis. Unlike the normal gap acidoses, we don't need a VBG to prove that we have an anion gap acidosis. By definition, an increased anion gap is an anion gap acidosis. The only reason we might get a VBG is to see whether or not there's an appropriate pulmonary compensation. Now, there was a wonderful article in the New England Journal of Medicine a number of years ago. When I say a number of years ago, remember I've been reading the New England Journal of Medicine since 1971 when I was a first-year medical student. So how many years ago it was, I can't remember. But it was helping put together a review of anion gap acidosis. And one of the things that I learned from that, and I've used it my entire career, is that anion gaps of 25 or greater, we can almost always figure out what it is. This is not that. This is a lower anion gap. This is only 20. Many patients come in the hospital with bicarbs of 18 to 20, maybe 17, maybe 16, have a mild anion gap, maybe 18, maybe 20. And residents know that if they just give them some fluids and let them eat the next day, that they're probably going to be okay. People get sick, they don't have much intake, they get a little volume contracted, they get a little lactic acidosis, they get a little ketosis, and we don't need to work up every anion gap of 16 to 18. We don't really need to work up every one of 20, except that this patient has ataxic confusion and slurred speech. And the question is, does that have anything to do with this anion gap? Now, many of you have heard me talk about this before, but the way that I've thought about anion gap acidosis for the last 20 plus years is through a mnemonic that I made up called Kill You. The reason I use that mnemonic, it's sort of like a schema. It gives me 4 categories of things to think about. And I like that kind of mnemonic rather than a list like mud piles of a variety of things that don't seem to fit together. And one of which I actually saw peraldehyde used once when I was an intern to prevent DTs. That was the last time I saw it or smelt it. And that was it was the second half of my internship was 1976. No, even back then, everybody knew that benzos were better than peraldehyde. We'll get to Kill You in a second. Natasha has given us the VBG, and why did she give us the VBG? So we could see whether the compensation was appropriate. And so remember Winner's equation. Well, you might not remember Winner's equation, but I do. Winner's equation is actually the calculated bicarb. So we don't have the calculated bicarb. We'll assume it's the same as the fluid balance profile bicarb, but it's not always. So it really should be the calculated bicarb because that's the way they created the formula. So it's 1.5 times the bicarb. So 16 times 1.5 is 24. Plus 8 is 32, plus or minus 2. Here the CO2 is 33. So the PCO2 is appropriate for the bicarb. And so therefore this is a compensated anion gap acidosis. It's a simple anion gap acidosis. It's not a dual metabolic respiratory problem. And because of the delta gap, it's not a dual metabolic problem. Okay. The K stands for ketoacids. We got 3 types of ketoacids. I'm going to challenge y'all. What are the 3? Put them in the chat. See if you can remember what the 3 are, and then I'll give you feedback. See who types fastest. Okay, so you're both telling me what keto acid, but not the clinical cause of the ketoacidosis. So DKA, that's one. Starvation ketosis, and that's usually a fairly small. So diabetic ketoacidosis, first of all, the patient has a normal glucose. Unless we find out that the patient's on SGLT2, that probably rules out DKA. And that's new teaching, and we can't forget that ever, that SGLT2s can cause a normal glycemic diabetic ketoacidosis. But we don't have any reason, we haven't been told that. Alcohol can cause a ketoacidosis. And several of you mentioned beta hydroxybutyrate. About 10% of alcohol ketoacidosis is not picked up in the urine because the urine picks up acetoacetate. And if they're in anaerobic metabolism, all the acetoacetate goes to beta hydroxybutyrate. There are places where beta hydroxybutyrate, if you order serum ketones, you get beta hydroxybutyrate. I actually worked in one such hospital. That's actually better for making that diagnosis. So alcohol, DKA, and starvation. We'll get to propylene glycol in a little while. Okay, so that's the ketoacids. This is probably not diabetic ketoacidosis. This could be starvation ketosis. It's probably not alcohol, though ataxic confusion, slurred speech, we might have to ask about alcohol. Okay, so that's the K. What the I stands for ingestions. There are 3 big ones. I'm waiting for you all to type again. So methanol, and even alcoholics rarely drink methanol anymore. People with alcohol use disorders occasionally drink ethylene glycol. It's been used in murder attempts. It's been used in suicide. It is used, and we saw a patient a number of years ago who drank moonshine, and the moonshine was flavored with ethylene glycol because ethylene glycol is very sweet. It's hard to get ethylene glycol now, much harder than it used to be. And do you know why we don't use ethylene glycol as an antifreeze anymore? Does anybody know? It's a good trivia question.
Is it because a lot of children got into it and drank it because they thought it was something like Kool-Aid because it was bright blue?
It actually wasn't the children.
Oh,
there weren't a lot of children. It was the dogs.
Oh, like this one.
It was the dogs. So yeah, dogs were getting into, in the garage, they were getting into the antifreeze. Okay, and what's the third one? You all have it in your bathroom, in your cabinet, if you have any over-the-counter medications in your cabinet. And you all know this. Aspirin, yes, salicylates. And you can get salicylates a lot of different ways. So it's not just aspirin, it's any way you can get salicylates. What is peculiar about salicylate toxicity that makes this unlikely to be salicylates? Right, you get a respiratory alkalosis along with anion gap acidosis. And that's why we needed the VBG. And that sort of gets rid of that thought. And I actually solved a clinical problem solving case that was presented to me at a national meeting one time. It was a patient who was using some Chinese. She was from China, and she'd gotten these pain patches from China that she had all over her skin, and she had an anion gap acidosis and respiratory alkalosis. And I deduced that there had to be salicylate in those pain patches, because that's what it does. Then there are a few that we rarely see. Iron, this would be more important in infants if they got into their mother's liquid iron. We can't get adults to take much iron, so I've never seen anybody overdose on iron. We used to see INH. That causes a mild lactic acidosis. That was before directly observed therapy. We'd send people home with 100 tablets of INH, and they decided to overdose on it. And then the newest one that is at least on renal boards is acetaminophen. And acetaminophen, correct me if I'm wrong, but I think it leads to increased oxyproline. And so it can cause an anion gap acidosis. Again, this is usually one of the little old ladies who take a little bit too much. Although I actually saw acetaminophen cause a problem in a woman who was taking OxyContin. Yeah, I think it was OxyContin. OxyContin has acetaminophen. No, it wasn't OxyContin. It was it wasn't Percocet. It was one of the other opiate acetaminophen combinations. She was taking that and acetaminophen, and she was like a 40-kilogram woman. It was the predecessor of Norco. It wasn't Norco. I forgot what we used to use. Yeah, Lortabs. Yeah, it was Lortabs. She was taking Lortabs and acetaminophen. And there was one case of an acetaminophen overdose in the ICU that had a persistent metabolic acidosis, and the resident actually got an oxyproline level and was elevated. So it probably could occur with that also. It's just something to keep in the back of your mind. That's really unusual. Then the L stands for lactic acidosis. We're going to divide lactic acidosis up into two big buckets and one little bucket. The big bucket is what all residents see all the time, and that is decreased perfusion of tissue. That could either be shock, it could be a dying leg, could be dying gut. Any tissue that's dying is going to produce lactate. We see it a lot in shock, and when you're in the ICU, you see it all the time. So that's type A. That's type A. That is, we physiologically understand what's going on. Type B is, it's not physiologic. So there are a variety of different parts of type B. There are some tumors, more often liquid tumors, although this is pretty rare, that produce lactic acid. So you need to keep that in the back of your mind. Then there are a number of medications that cause lactic acidosis. There's an HIV medication that causes severe lactic acidosis, DDI, that nobody uses anymore, I don't think. Linezolid can do it. And I think propofol can do it. Then there is the famous propylene glycol that somebody mentioned before, where if you give IV medications that have to be dissolved in propylene glycol in order to make them IV. So one of the things you have to think about is that anything that's delivered as an IV medication is dissolved in something. And Ativan, and I should use the generic name and I just forgot it. Does anybody remember the generic name for Ativan?
Lorazepam.
Lorazepam. Thank you, Natasha. So lorazepam is dissolved in propylene glycol, and there was a number of articles, this is maybe 10, 15 years ago, of people who were getting more than 7 milligrams per hour of IV Ativan. The kidney could only excrete around 7. Propylene glycol gets broken down to acetoacetate and lactic acid. you can get rid of the ketoacetate, you can't get rid of the lactic acid. And so they could get really sick and die. And then there's the famous type D lactic acidosis. Now, why is it type D? Because it's actually D-lactic acidosis. It's an isomer. We normally, the lactic acidosis that we normally measure is not type D. Type D is when bacteria break down carbohydrates, they produce type D lactic acidosis. This occurs primarily in people who have bacterial overgrowth in their GI tract. So it's fairly common in people who have Roux-en-Ys, but any abdominal surgery that will lead to decreased flow through the GI tract and increased bacteria, they'll produce D-lactic acid. Now, what's interesting about D-lactic acid? Well, first of all, one of my colleagues who you all know, Dr. Chad Bursky, when he was a resident, he made a brilliant diagnosis of D-lactic acidosis in a patient, and he and I wrote that up as an article, and I will make sure that we add that reference to this by sending the reference to Natasha to add in. And we go through KILU in that case. Normally the anion gap is around 18 to 20. And patients come in, and that patient in particular came in telling, and this is the third time she'd come in, saying that she felt drunk, but she had an alcohol level of 0, and she had an anion gap of 18, and she'd had a Roux-en-Y. And he sent off a D-lactic acid to the Mayo Clinic and proved that that was the problem. The treatment is either to give them antibiotics to decrease the amount of bacteria because of the bacterial overgrowth, but the biggest reason is to get them to eat less carbohydrates. The patient that Chad saw when he was a resident had come in 3 times, and on a review with the patient and her family, it turns out that each time she came in with D-lactic acidosis, she had been out eating pasta, and that's a lot of carbohydrates. So that's a rare one, something to think about. And Julie, you just saved me. I was about to forget that. One of the causes of a type B is thiamine deficiency, and that is really, really important. So thank you so much for remembering that, because 15 minutes ago, I had in my mind that I was going to talk about thiamine deficiency, and then I just started talking and not thinking well enough. Thiamine is a cofactor, and if you don't have enough thiamine, you don't leave lactic acidosis. And I have diagnosed that in the hospital before. Patient who was admitted, and they thought they were septic because they had a lactic acidosis, and we made sure the patient's volume expanded, and then we finally figured out that it was probably thiamine deficiency. 2 things about this. Number one, thiamine levels are not perfect. So and they take a long time to come back. But if you send a thiamine level and it's normal, that does not mean they don't have thiamine deficiency. So the test you have to order is transketolase, because that's a cofactor, and it'll be abnormal if they have thiamine deficiency. But we probably will just empirically give thiamine to a whole lot more patients than we do. And there's a very interesting article in the Annals of Internal Medicine in either late November or early December of 2021 that says that in intensive care units in this country, in people with known alcohol use disorders, we don't regularly give thiamine as often as we should. So empirically giving thiamine will fix that. And that's just another reason we ought to be giving patients thiamine, but really, really important. So Julie asked a really good question. And that question is, do we need to measure thiamine? no, we just need to give it. I've never heard of a thiamine overdose. So if it crosses your mind, just give it, and just give big doses, and it'll probably help. I just don't think it's worth the money and the time to wait until that happens. Finally, the U in KILU stands for uremia, and that's usually hyperphosphatemia. Now, so how are we going to work this patient up? Well, I think we're obliged to get a serum osm, because the serum osm is going to allow us to look for methanol and ethylene glycol. The only thing against that is 3 days of ataxia and confusion. They should, if it was methanol, they'd already be blind, and if it was ethylene glycol, they'd already have renal failure. So that 3 days really makes those unlikely, but we'll go ahead and get a serum osm just to make sure there's not an osm gap. And the serum osm is 298, the gap is 5, but we didn't really suspect that. We got rid of the salicylates because there wasn't a concomitant metabolic alkalosis. The lactate is normal, so it's not thiamine deficiency, it's not all this stuff. I want to get a history and see whether or not there is a history of GI surgeries, and the question is going to be whether or not this patient might have a type D, because it's the right clinical syndrome. She had a small bowel resection. So I would take a history. Has she taken in a lot of carbohydrates? And if she has, we could send the lab test off to the Mayo Clinic. It'll come back in about 2 weeks. The patient will be discharged. We will have taken care of the patient fairly well, and advise the patient not to eat so many carbohydrates. But I think that's probably what's going on. So Natasha, can you give us the big reveal?
Yes, so that her exam is pretty unrevealing, but yes, that is correct. So this is a case of type D lactic acidosis. It was a case that was inspired by one of the mix-up questions. So it's a very good test topic. And I actually, while Dr. Centaur was going through this episode, found some notes from an unRemarkable Labs episode last year where I had written this down too. And so I don't have a lot more learning points because Dr. Centaur did a really good job of going through everything. But I also like the KILU mnemonic. I think I like compartmentalizing things in my head. But I think, like he said, type A is what we see most commonly, even on the floor. We'll give a little bit of fluids, it'll get better. Nothing necessarily to work up. Type B, I think thiamine, I saw a really interesting case of that one time. It may have been on unRemarkable Labs actually. So it's something to think about. And I've made it my practice to where if somebody comes in encephalopathic, they're automatically getting IV thiamine, no questions asked. Because there have been times where I've given it just because, and it came back low, even though I had a very low suspicion. So now at this point, I just always give it. And then propofol was something I didn't necessarily think of or didn't necessarily realize, which is interesting because how many patients in the ICU have a lactic acidosis that we attribute to shock that could potentially be due to propofol? So just something to consider. And then of course, our patient had a type D lactic acidosis. And I think it really comes down to history, because how many times do we copy forward, especially in the ICU when we're busy and we don't get a great surgical history if the patient's new. It can be really helpful because a patient, with a Roux-en-Y you may not know that. If they have an ostomy or something, it's more obvious and you're more likely to think about it, but just goes back to how important taking a good history is. Those are the main learning points I had.
So Julie, what do you want to remember from this conversation?
So after having you as an attending, I'm familiar with KILU. I think what I'm taking away this time after learning the KILU mnemonic again is specifically the medications that can cause a lactic acidosis, because I've actually had a patient on the floor that had a type B lactic acidosis from thiamine. So I've experienced that, but I haven't really considered different medications in my differential diagnosis that could cause it.
Yeah, so I think we're all suboptimal when it comes to looking at the medication list and trying to figure out, could that be the cause of all the problems? And we all fall into that trap of not thinking through that as well as we should. So that's a wonderful point, Julie. Yasmin, what do you think?
This was I have always been taught the mud piles, but I feel like the Thiel mnemonic is just so much more pertinent. And then I guess I did have a question about the type B lactic acidosis, if it was the same, like if you treat it the same way that you treat lactic acid, the normal one, in terms of values, if you have like a upper threshold where it's usually high or elevated.
So if it's tumor, you'll have an elevated, and it's persistent and elevated, and there's no other explanation. And then so you try to treat the underlying disease. If it's a medication and you think of it, then you try to stop the medication and see if it goes away. The propylene glycol is really much more rare than it used to be. There used to be a lot of IV lorazepam used in ICUs, especially in people with alcohol use disorder going through DTs and aspirated and had to be on a vent. That's not an unusual combination. And so people liked IV lorazepam because it was good for the withdrawal as well as good for maintaining the airway. But they ran into this lactic acidosis. And once they understood that, I think that's why they use lorazepam so much less frequently than they did 15, 20 years ago. I think that's about it. And the thiamine is just, as Julie said, think of thiamine and give thiamine and see if it just gets better. And Miles, you get the last word.
Well, they already talked about the kill you, so I would just comment on how important it was and how good it was to watch you go through that very initial step of seeing the low bicarb and then methodically going through, okay, what is the primary metabolic acidosis? Is there a gap? Yes. Is it compensated? Once you're seeing that, you know that it's a gap, then looking for other causes of non-gap acidosis or alkalosis. And just really getting that so strong at the beginning so that you can get to your kill the mnemonic and be confident that you're in the right area to start with. Yeah,
and that's something that both Natasha and Julie have seen me do way too many times. I'm a little bit obsessed with it, but I've made a lot of diagnoses because of that, by going through carefully. And I think that the other point that I would stress is that when you look at the labs, that if you look at them carefully, they often raise questions. And even if you've already done the HPI and the review systems, it may drive you to go back and ask some other questions. My feeling is we get the labs anyway. We might as well interpret them. And that's the whole idea behind unRemarkable Labs. Thank you all so much for being the voice of all the listeners.